I really admire that all what you do, right? Like this initiative of the study club is something beautiful. I wish you had done it when I had that right here. But anyways, it's going to happen now.
Right.
And you selected a few of us, and I'm happy and honored to be there.
Yeah, honors all ours.
Yeah. So I'm not full time. I won't be full time academician anymore, as you know. But yeah, I'm still academician at heart.
Right. We all are.
Yeah, exactly.
Right. And anybody at this level of their career and education, we need to be. We need to be, or else we're going to become dinosaurs. If we're not, like the way I practice now is totally different than when I graduated. And I graduated like 5 years ago, you know, and my practice right now is completely different than when I was in residency. And this is how it should be, right? If I'm still doing the dentistry that I used to do 5 years ago, that's a problem.
Yeah.
But most people are like that. We're like, I did this in school. My professor told me 15 years ago that I should be doing this way, and this is the way it is. It's like, no, things change literally daily.
Yeah.
You know, and especially now moving on with AI, you said that maybe scientists could be, AI could be replacing scientists. Things are going to go drastically crazier. So new things will be coming to light, which brings me to another point. Let's talk about dentistry, you know? So let's talk a little bit about prosthodontics, and then we'll move on to implant prosthodontics.
Super.
Let's talk a little bit about veneers. I know us as prosthodontists, we're prosthetic specialists. Anything to do with prosthetics, it's us, and not cosmetic dentists. I don't even know what that is. So everybody's always asks me whenever I'm in conferences, what cement do you use? What cement do you use? I'm like, well, first the clinician needs to be good. I think that's the most important. And the lab needs to be good. But also the way you cement is also important. So what cement do you use in your practice? And do you use light cured or dual cured?
Yeah, that's a very, very loaded, interesting
question. Very loaded. And it's a very common question.
It's a very common question. Yeah, well, depends, no? If it's an area that is visible in the mouth, right? Like it's visible to the public, well, you need to be more concerned about those aesthetic nuances, right? Especially with the dual cement, you might suffer some discoloration. Right. So in that case, you might go for a light cured cement. However, you need to also keep in mind about the thickness of that restoration, because you need to make sure that the light is going to penetrate
and
to properly cured. Exactly, and the material. That's very important.
Yeah. And what do you think about zirconia veneers?
Oh, that's very, very interesting. We've done some research about it.
Okay, tell me.
Yeah, well, we're just looking at the flexural strength and fracture resistance, and I mean, they're great, right? You can use them.
Zirconia is an amazing material.
Yeah, but probably, in terms of the bonding, right? That's where we might have our weakest link, right? But yeah, we need to be conscious about having.
Do you think we can bond zirconia?
I think we can improve, right, how the zirconia is cemented by creating some, mechanical retentive features, like as we used to do, right? When we do.
Well, that's cementing, but do you think we can bond it?
Yeah, that's something that we.
What do you think about the protocol from Penn? Forgot his name, Professor. Blatz, yeah, from Penn. The APC concept, where he air blasts and then primer and then cement. Do you think that will create a bond?
Well, I can tell you that there's always been this controversy, right? Should we air blast, right, with the aluminum or not, right? So some say yes, it's going to create this micro retentions, so it's going to be greater. Some say like no. Right, so you're already modifying your zirconia, so it's going to become a little bit more brittle. I think either or is still going to work beautifully. Yeah.
Okay. What about another question that I get very often from colleagues is post and core.
Yeah.
Do you use cast post and core, or is everything just prefabricated posts or fiber posts?
Yeah. Well, nowadays. Post and core that is customized is I don't think it's used that much. anymore, right? Thanks to the advances with aesthetic dentistry, we have
and
available
bonding.
this, bonding. Yeah, we have these beautiful fiber posts. We know, they are not as rigid, but then you don't have, the roots that are being
catastrophic failures, right?
Exactly.
I rather it debond or break off than the tooth fracturing, right?
Exactly, because it just becomes a complication. Right. And you have the situation where you might have a post-encore, right? That you might use. I can probably remember some upper canines that I've used, probably zirconia post. Some situations have to do, with the anatomy also that you have of the root. Sometimes of the remaining coronal tooth structure. If it's really minimal, really compromised, maybe it's a good idea to use still a custom post-encore.
Okay. Yeah. I guess it depends on the situation. What about post-encore in molars?
Yeah, post-encore molar, I still would go with how much of remaining tooth structure is there, right? And then I can still go with the fiber post. I'm pretty comfortable with it. Okay. Again, you have a build-up that is using composite. I'm still surprised that I see a lot of colleagues, nowadays. It's still they're super young, right? And they're using amalgam, right, for their post-encore, right?
Yeah, but at least in the US boards, we have to use amalgam for cores. Because research, at least classical literature, still shows that it has the least plasticity, which makes it a great core material.
Wow.
So I don't blame them for that, but it is old school.
Yeah, I'm surprised.
Me personally, I don't do post and cores on molars. I think the pulp chamber is a great post and core in of itself, because like the pulp chamber just goes all the way down.
So you prefer
just build that up, and you really don't need to, because it creates such a nice retention for the pulp chamber. But when it comes to like premolars and premolars and anterior teeth, I'll do mostly fiber posts. I rarely, because I think you can go shorter, because you know how post and cores, when you're preparing the space, you're actually weakening the tooth. So with cast post and core, you have to go deeper. You have to go at least 3/4. You need to have a certain width. You need to have certain dimensions, that you're removing the actual tooth structure. So you're actually weakening the teeth. But with a fiber post, because of bonding, I can have a shorter post and I can have a thinner post. So then it will kind of last longer. And I'm relying on bonding, which is fine as long as it got a feral effect. I've really shied away from cast and post. I think the last time I did a cast post and core was for my US boards, because we have to do it. What about endocrowns? Endocrowns are crowns that you're using the pulp chamber as part of the indirect restoration. Do you do those or not really?
I've done a few, but
do you like it?
It's something I didn't. It's something like a trend. It happens that it's not the first time that we're doing.
But trends don't work in healthcare.
Yeah, exactly. Yeah.
Leave that to TikTok.
No, exactly. They come and go, right? So this is probably the third time that endocrowns make.
Well, they're doing endocrowns now. There's a recent study from Manier from USC who started doing endocrowns on anterior teeth.
Oh, wow. That's interesting.
Yeah, which is very interesting, because I feel like you're going to be removing a lot of the tooth structure to create that retention. And from his study, it seemed like it was working.
Wow.
But I think that needs a little bit more research for that.
Yeah,
me personally, I'm not a big fan, because crowns have a lifespan. You bonding that, I've tried, I don't know if you've ever removed an endo crown before from a tooth. It is extremely difficult, because the whole thing is bonded. It's bonded from within. Yeah. So the possibility of fracturing the tooth itself when you're removing the endo crown is ridiculous. So us as prosthodontists, we're always planning for failure, right? Yeah. You want to do something that's retrievable. You want to do something that you can kind of go back. But when you're doing an endo crown, it's just so hard to take it out if something goes wrong or you have a small chip, because you're also most of the time using Emax, right? So you're bonding it. And that could fracture, and then you're left with a disaster. You know, that's my opinion. I did dabble with it. I'm not a big fan.
Yeah, you mentioned Pascal Magnier, right? So he's another incredible professor, dental researcher. extremely nice person as well. By the way, he was also trained by Belzer, right?
Oh, no way.
Yeah.
Oh,
So there's something in
interesting.
common. And he's one of those who inspired me also to leave academia, because he already left academia. He had
Really?
enough.
He's not in USC anymore?
No, he's not in USC. He's still in
Interesting.
California. He's more involved with continuing education and also with some dental lab.
That's very interesting. All these like giants are leaving academia. I guess you're right.
Yeah.
Well, also like at Harvard, we had H.B. Weber. H.B. Weber is a giant in implant dentistry. He also left. He's with Clear Choice now.
Oh wow.
Yeah, so
that's quite
he's
a
in private
surprise.
practice. You know, he's been an academician his entire life, and then now he's in private practice.
By the way, he was also trained in University of Bern.
Right.
Yeah.
Right. Okay. That's with classical prosthodontics, let's say. Let's move on a little bit to implants. And you being an educator, nowadays, I think at least in North America, in dental school, they're starting to teach implants, surgical implant placement. What's your thoughts on educating dental students using guided versus freehand?
Okay, so that can be also controversial, right?
Let me explain a little bit, at least for the audience. Freehand meaning you're placing the implant by yourself without a guide or without a computer guide. And a computer guided surgery is where you pre-plan it in the software. You know exactly where you're going to place it, and then you create you the hole, the osteotomy, and then you just go straight in. So what's your opinion? Which one should come first? In terms of training?
Yeah, so that's a very interesting situation, because they say, right? Some say that students should just learn computer guided and that's it. But I think it's good for them to learn also freehand or brain guided. Just because,
I like that.
That's how Danny says it, right?
Oh, really?
Brain guided.
I like that.
Instead of freehand. Anyway, so because they need to know about the surgical anatomy, and not always, a surgical guide might be fitting correctly, or something goes bad in the way.
You need to troubleshoot.
Exactly. So knowing also about the angulations, I think three dimension of the placement of an implant, I think is very important. So actually mastering both is extremely important.
Right.
I think, any dentist who really want to know or practice implant dentistry, they should be able to master both.
I completely agree with that, because I think the concept of pre-planning everything and virtually placing the implant on the CBCT and in the software lets you see all the elements that you don't really recognize in real life. So that part, along with the freehand, I'm a big believer of freehand. I do guided. I do a lot of guided, but I do way more freehand.
Super.
Mainly just to decrease cost on the patient. But in my training, we did freehand first. We were told you master freehand and then move to guided, because guided is easier. But figure out the hard parts, and then if anything goes wrong with guided, then you'll know how to fix it. But if something goes wrong with guided and you don't know freehand, then you're in trouble.
Yeah, and also you want to stay with guided, especially when you want very predictable outcomes, right? In case that might be highly aesthetic demanding, right? That might have a high lip smile line, or a case where it might be super complex, right?
Right. Absolutely. There's a lot of research that came out of, I think, University of Bern with zirconia abutments straight to titanium implant platforms. I think there's still an advocate for that. The last time I was in the global ITI, they still talked about that. There's certain guidelines for it, but they're still okay with it. What's your thoughts? Being that you're Western educated and Bern educated.
Well, I think there's a place for zirconia abutments, right? It's not for every case, obviously.
What's your guidelines?
Yeah, well, should be probably in anterior zone, right? Where you're going to have probably less stress. An area that demands, highly aesthetic results. That's it. Otherwise, why would you go for that, right? Because you might increase the chances of a fracture. So I think we're doing pretty well with our titanium-based or hybrid design that we want to have this.
Why risk it? And that was the point. It's like, why risk it if you know that there might be an issue? So I think their guidelines was updated that not use on narrow platform just to get a good enough thickness.
Yeah.
So with like a 4mm, 5mm implant, then maybe you can in the anterior region. But like the Straumann 3.3, avoid that because that could easily break and that will create a lot of issues. I've never done it. I think we're doing a great job with our prefab tie bases and with our customized zirconia abutment, let's say if needed. And you can get the best of both worlds, right? You still have the zirconia that's compatible with the tissue, yet your connection is still titanium. So I do like that. What's your thoughts on bone level versus tissue level as a prosthodontist?
Yeah, that's a very good question, Rami. So as a prosthodontist, you know that you have more of a control of the emergence profile when you go with the bone level, right? And when, cases that are not that highly demanding in terms of aesthetics, you can go with the tissue level, posterior zone, and full mouth rehabilitation just is easier for the maintenance, right? And oral hygiene of the patient. I think that's basically it.
What about placing tissue levels for full arch cases?
Okay, so well, depends what's going to be your full arch case, right? You need to look at the anatomy, right? You need to look at the soft tissue health as well, and then I think that's going to help you to decide. Also, the prosthetic design, because it's very different if you are treating an FP3 or you're going for a implant over denture, right?
Oh, absolutely. I once had an interaction with this periodontist in Abu Dhabi, actually. And we kind of got at it because he said that he places tissue level for every single case.
Wow, all right.
No exception. I was like, sometimes you need bone level. And he's a periodontist, he's not a prosthodontist, so he doesn't really understand what goes on afterwards.
Yeah.
And I was trying to explain to him that, hey, sometimes you need the versatility of a bone level in order to place it. And he's like, absolutely not. All my full arches are tissue levels.
Okay.
And so we agreed to disagree. So we left it at that. Like, you do you, just don't refer me any cases, and I will definitely not refer you any cases. Okay. I think another struggle coming to education in general in the UAE is I get a lot of students who want to do prosthodontics, yet they do not want to do complete dentures.
Oh.
And I immediately tell them, do not become a prosthodontist. And they're like, why? I'm like, if you do not know how to make a good complete denture, you will be a terrible prosthodontist. That's correct. What's your take on that? Do you agree with me?
I totally.
Or am I being too harsh?
No, I think you're being too nice. But I totally agree.
I like you.
I totally agree with you because, I mean, how can you be a great prosthodontist, right? Handling all these full mouth rehabilitations if you don't know the basic principles. Because there's a huge overlap about the complete dentures with the full mouth rehab, whether it's good with implants or whether it's going to be with teeth, especially when you go for a reorganized approach, right? So I think that definitely you need to be great. Yeah. But I do understand them because if you see what's happening outside, right? What's happening in the market, that you have dental technicians that might go to the clinic, they will take the impression, they will take the video, and they just don't care, right? So that's it. Why should I learn this? Yeah. So I had a lot of difficulty teaching, complete dentures here, and not only here, Canada as well.
Really? That's very interesting.
Yeah, because there we have denturists. Is that
an actual license?
Yeah, that's an actual license. So it's like a dental technician that
can work on patients.
Yeah, can work on patients, can do dentures.
Interesting.
And not only that, now they can, in some provinces, they can do implant prosthodontics, right? So that's incredible. Yeah.
Is it because they're lacking so many dentists?
I don't know. It's just because I think the Prosthodontic Association, probably we should be a little bit harsher in terms of what
we're just
gets
letting
accepted
them
and what not.
Step all over our field. That's insane. I actually did not know that. But with a complete denture, it teaches you where to place the central incisors in 3D space.
Yeah.
If you cannot do that, you're not going to be a good prosthodontist. And some of them don't really understand that. And they still go into pros and they end up being terrible prosthodontists.
Yeah, exactly.
You know?
Exactly. You need to know for sure where it's going to be that maxillary incisal edge, right? Where you're going to have the zeniths for your margins. Right. It's like the angulation of the teeth as well.
And that's, at least for us in our training, at least in the pros training, one of the cases that we need to present to the board to become board certified is a complete denture. And we have to do it a completely balanced occlusion.
Wow.
Meaning that when you're moving your jaw right and left, both sides on the right and the left are touching, which is extremely difficult, extremely useless, but it's a good exercise in terms of skills. So I don't think it's necessary in most dentures to do a bilateral balance. I don't think anybody knows what that is in the UAE. But it was a great learning experience to be able to accomplish that.
Yeah, that's what I noticed, right? Like in terms of occlusion, they see it as static occlusion only.
Right.
But you just summarize it very nicely in terms of function. You need to know how your condyle, how your mandible, right? All those excursions, how they work.
Right.
And so if you cannot do complete dentures, then you're out of the game because you cannot control occlusion, function, and aesthetics.
Right. And especially now, because now we are doing a lot of implant prosthesis, full arch prosthesis. It's becoming so common. And the basis of full arch implant prosthetics is a denture.
That's
so
correct.
like you start with a denture and then you build up your prosthetics, your fixed prosthetics. So you still need to know dentures in order to do implants.
That's correct.
So yeah, that drives me crazy. Moving on to dentures, more into dentures. As a private clinician or a private clinician, I try to help patients our responsibility is to give options.
Yeah.
And part of those options are overdentures because it's still an amazing treatment where the prosthesis is attached via implants, but it's still removable. So it just clips on. And nobody wants to do that. I haven't had a single overdenture in the UAE. And even though I explained to them, being like, hey, this is going to cost you 40, 50K, this is going to cost you like 10K, and you'll still enjoy and your quality of life is still going to be really, really good. And they say, no, I'd rather be with no teeth than to have something removable. What's up with that? Did you experience that?
Yeah.
Why do you think that is?
I did experience that. And I remember speaking to my medical director, you know what, I can provide this kind of treatment. I think this is a beautiful treatment. We have a lot of literature from Japan and Germany, which is supporting it with long-term, outcomes and survival. It's just beautiful. But he said, like, forget about it. And then I said, why? Yeah. Then he made me realize that, in the culture, they don't see them like something necessary when you have the fixed option where it's seen as more luxurious, more modern, therefore becomes more popular. Right. But also, it's also our responsibility to provide them with treatments that are at different costs. So let's say doing a full arch on implants, let's call it the BMW or the Mercedes. It's like, but if you don't afford that, you're gonna have to go for something lesser. That's still good. It will still take you from point A to point B, which is chewing your food, quality of life, and all of that. Yet they rather walk and have no car than to have a car that does its function. It boggles my mind. But I still try, and it's my responsibility as a dentist to inform them of these options because they can go back and be like, "Why didn't you give me that option? That could have improved my life." But I still have failed to convince a single patient. We're in the same boat, and you're doing excellent. I mean, we are obliged to give all the treatment options to our patients, whether they consider it or not. And sometimes I feel I'm wasting my time, their time, my saliva by telling them about the implant overdenture, right? So I think another thing that I see a lot is when we're assessing for full mouth, going back to complete dentures, when we're assessing full mouth rehabilitation on implants, the lack of knowledge in restorative space. I'm a implant privilege examiner, and I see that a lot in the applicants that apply, and there's absolutely no knowledge in that. Why is that? Do you think it's necessary to have restorative space or an adequate restorative space in the era of zirconia,
being strong 1,200 megapascals, which is insane.
Yeah, I totally understand what you mean, Dr. Rami. So, yeah, materials are constantly evolving, right? So we try to make them thinner and more resistant, stronger. But I think there's still a place for knowing about,
but there has been a shift. Like if you think of it, when I was in residency, it was, hey, you need 18 millimeters, you need 15 millimeters of space to do that full arch, even if it's in zirconia. But now we're going way, way, way thinner, and we're doing FP1s. Yeah. And FP1 is just zirconia with no pink, right?
Yeah.
Which doesn't really need a lot of space. What's your thoughts on that? Do you do a lot of FP1s?
No, I don't do a lot of FP1s, right? Okay. If you do need to do an FP1, the case have to be very specific, right? So you should have a lot of alveolar bone, alveolar ridge. The hygiene of the patient should be impeccable. So how many cases do we get like that, right? So
it's been a handful, but also I think a big part of that is a very skilled surgeon, in my opinion. Doing an FP1 means that you cannot have the implant in the embrasure, meaning that it has to be exactly where the tooth was in order to accomplish that. And that's what the ITI teaches us, right? Yeah. ITI teaches us, okay, if you can do split, will be much better, but you need to make sure that your implant is in the right position. And that's also another problem here. When I get referrals for full arch prosthetics where the implants are already placed, and it's just like somebody got a bow and arrow and just like shooting their implants wherever it is, as long as it's in bone. Yeah. The prosthodontist will deal with it, and that's kind of sad.
Yeah, that's what we try to explain, right, to some of our colleagues or patients. Like, patients need teeth; they don't need implants. Why place an implant that is not possible to restore?
Right. Oh, we get those cases so many times. Like I recently had a case. Patient was lacking 2 premolars, and there was space only for 1, but they wanted to place 2, obviously for more money. Yeah. And they placed 2.9 Straumann implants on like opposite like this, and they were not restorable. I had to remove them. We had to remove them, and she goes through all these surgeries, all these extractions and all that, and then they were not restorable. They ended up not being restorable, and we had to remove them and place new implants. Yeah. And we just placed 1 like they should have. It's
sad reality.
It is what it is. It is what it is. I think lately there's been a lot of research on robotic implant placements where they remove the surgeon there's no surgeon. That happened in the States very recently. We saw that where they did an entire procedure robotically. And currently, or the past, I would say 5 to 10 years, actually NYU has been dabbling a lot with that, with the Yomi, where it is robot assisted, not completely robotic. What's your thoughts on that? Do you think that's the future?
Yeah, we have published about it. We have appraised actually some of the research that has been done regarding it. I can tell you that, it seems that it's going towards there, right? But we're not still at the point where we don't need clinicians anymore, right? We don't have to be we don't have to be worried about it. But these magnificent results, predictable outcomes. So in anterior zone, I've seen that they're doing very well. That's where they're placing most of the implants by using the Yomi, and we can tell that it's getting better and better, right?
Yeah. Oh, absolutely. I think it is the future. It's not there yet, but I think that's the future. Just like how we went from brain-guided, freehand, to computer-guided, robot-assisted, robotic. And we'll take it from there. And let's take the other side of it, going from technology to biology. Did you see the new research that came out of Japan from Torigem Biopharma about the USAG1 jabs? Very interesting. So they had research where you get injection with this protein that blocks something in your protein genesis
Then you can grow teeth.
and then you can grow teeth.
Oh, okay.
And that was successful in mice, and they published about it, and there's a whole thing about it. Do you think that is the future?
That's where we're going, right? But I think we're still a little bit far, or God knows, right?
Yeah.
Because I mean, what we have advanced in the last 5 years is
insane.
it's just amazing, right?
Yeah.
We never thought we would have done such a progress, even in 20 years, but we did it just probably in 5 years.
Right.
So yeah, things are going
It's
very quick.
insane. It's insane.
Yeah.
Like the biology of it. And I'm glad that there's people still working on biology rather than just technology. Because you see the world we live in, Meta, Nvidia, all these companies it's all about and they just got out, Google just had a quantum chip that's stronger than anything that proved the metaverse exists.
Wow.
The world is going crazy technologically, and I'm glad that there's still companies out there that's doing biology, right? It's just so simple, but it's just so important. And let's leave it at that note. It's just so important to continue research. It's so important to continue doing what we're doing, and continue loving what we're doing. So for that, I would like to thank you. So what's next for you? What's next in the adventure of Dr. Kelvin?
All right, thanks for asking, Dr. Rami. So yeah, I will just keep doing what I do. So I told you I love academia, so I'll be involved in study club, some continuing education, publishing the papers that I still have left, thanks to the trust from my co-authors, and in clinical dentistry. I just wanna provide to people bright smiles, make them feel good every day, and one smile at a time.
Yeah, and that's the trick, right? So this is what we do. We do what we do, although patients hate us for some reason. The second they walk in, I hate dentists. We're like, well, we hate you too.
Exactly. We all get that, right?
Ridiculous.
Yeah.
But yeah, ultimately what we do is we just try to improve people's lives, right? We try to improve quality of life and give people teeth. So that they can just function and improve their quality of life.
Exactly, improve their confidence. And
keep doing what you're doing. You're doing an amazing job. So where can people find you?
Yeah, so basically you can find me here in Abu Dhabi, in Dubai. I'm just one click away, right?
Nice. So you've got an Instagram. Maybe they can reach you on Instagram.
Yeah. Okay. There we can have
awesome.
some conversation.
We'll put it on the captions and then the links and all that.
Excellent.
All right. Again, I would like to thank you for the opportunity to have this conversation. I think it was a lot of fun.
For sure.
We dabbled a lot in dentistry and academia and all that. It's all very interesting. We will definitely put in the links for all the research that we talked about. We'll put that on the captions. Everything is evidence-based. Most of it is probably his research, which is pretty cool because you're hearing it from the source. So we thank you again for coming here, and this has been absolutely a pleasure.
Thank you, Dr. Rami. It's been a pleasure for me as well. It's been really fun. Let's do it again.
Yes. We've been doing a lot of or scheduling a lot of debates.
Yeah.
So we actually have a debate coming up with Dr. Haytham and Dr. Ahmed. One is a UK prosthodontist, and the other one is a US prosthodontist, and we're going to be seeing the different ways education people think. So we'll definitely get you in one of those debates.
Super. I'm down to it.
I love it.
Let's do that.
All right. That's awesome.